As you've just heard, phase 1's primary goal is to optimize and protect the healing capsulolabral tissue. Some exercises are allowed during this phase, but the goals relative to early range of motion and strength are secondary and must be done within the limits of pain and without compensation. For the most part, exercises in phase 1 are done with the arm in the sling or supported in an adducted and internally rotated position. One exercise that we can do at this early stage is standing pendular range of motion. The patient can do this exercise with their arm in the sling or out. Two things to remember. The first is that the arm is unweighted, and second of all, the arm only moves to the circumference of a dinner plate. So range of motion is done active assist in this phase. The patient is allowed to move to 30 degrees of flexion, 30 degrees in the plane of scaption, and they can move to external rotation, but only to a position of neutral. This can be done in standing or supine as your patient is able, and you can use a cane or a stick to assist the range, or simply the patient's unaffected arm. Strength in phase 1 is begun isometrically. It should be done at a sub-maximum level, which is about 60 to 65% of the patient's normal maximum contraction. All of the shoulder movements can be done, including internal and external rotation, but the patient should be positioned either with their arm in the sling or resting in an adducted and internally rotated position. Both with resisted isometrics and active assist range of motion in phase 1, we have to be careful that our patients are doing the exercise properly and without compensation. Some of the early compensation patterns that patients will use is shoulder hiking. The other pattern to watch for is that their scapula will go into protraction, or when they're doing their external rotation, instead of the motion coming from the glenohumeral joint, they'll start to extend and rotate at the trunk. Scapular setting exercises are emphasized in phase 1. They can be done safely with the arm well protected in the sling or again in that adducted internally rotated position. And a strong scapular base is really important to establish at this early phase. When patients start to progress into more overhead dynamic activities, it becomes extremely important that they have a protected glenohumeral joint. So again, the shoulder is either in the sling or in this supported position. Patients should first do this exercise seated, but then they can progress to doing it on a physio ball and then eventually standing. The first step is to have your patient establish proper posture, so to give that cue as needed through the whole spine and into the C-spine. And then, depending on what you're working, your instruction is to have your patient, without moving their arms, bring the shoulder blades straight together for retraction and release, or to bring the blades in a down and in direction for retraction and depression. In addition to the shoulder exercises in phase 1, patients should be doing wrist, hand, and elbow range of motion and gripping exercises with the arm supported, and if warranted, more specific cervical and thoracic spine range of motion and posture exercises.